and then you can start. I've seen that Dr.
All right, sir. Okay.
Imad, can you make Dr. Rashid Jooma co-host? Okay. So I welcome you guys all to yet another session in the Residence Corners module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital, Karachi, Pakistan. The idea behind these sessions were to build anatomy, basically 3D anatomy, which is very important for young neurosurgeons and residents. Last week we discussed the anatomy of Sylvian Fissure and Insula, and this time we'll be discussing vascular anatomy. Dr. Daniyal is first year resident at Liaquat National Hospital. Our expert panelist today is Dr. Rashid Jooma. Professor Rashid Jooma was also there with us last week, and he was keen enough to join this week, which shows his interest towards education in Pakistan, towards neurosurgical education in Pakistan. He's one of my mentors, but also mentors of many practicing senior neurosurgeons in Pakistan. He has had great influence over the face of neurosurgery in Pakistan. He has held key positions in neurosurgery in Pakistan. I welcome Dr. Jooma again. Thank you, Dr. Jooma, for joining us.
Thank you, Saad.
Dr. Daniyal, can you start your presentation?
Yes, sir. Assalamu alaikum, sir. So today's topic of presentation is about Sylvian Fissure and insular vascular anatomy. So starting from a brief introduction about Sylvian Fissure, the Sylvian Fissure is the most distinct and consistent landmark on the lateral surface or on the brain. It is a complex fissure that carries the middle cerebral artery with its branches. It provides a surgical gateway connecting the cerebral surface to the anterior part of the basal surface and cranial base. Now discussing about the vessel of Sylvian Fissure, the most important one is middle cerebral artery. The middle cerebral artery arises from internal carotid artery, and it is the larger of the two terminal branches of internal carotid artery. Its diameter at its origin ranges from 2.4 to 4.6 mm with an average of 3.9 mm. That is roughly twice that of anterior cerebral artery. This image is showing the origin of middle cerebral artery after arising from carotid artery. This is internal carotid artery that is dividing into anterior cerebral artery and middle cerebral artery. So the origin of middle cerebral artery is at the medial end of Sylvian Fissure, lateral to the optic chiasm, below the anterior perforated substance, and posterior to the division of olfactory tract. This image is showing the anatomy. So this is the optic chiasm, and this is the medial end of Sylvian Fissure. And the middle cerebral artery arises somewhere between the optic chiasm laterally and medial to the Sylvian Fissure. This image is showing the origin of middle cerebral artery that is lateral to the optic chiasm. This is another view, that is the superior view of brain. The left cerebral hemisphere is removed. This is the nose. This is the superior sagittal sinus. This is the anterior cerebral artery. So the middle cerebral artery arises lateral to the optic chiasm, and it goes laterally towards the Sylvian Fissure. This image is showing, this is an enlarged view, the M1 segment, that is the first segment of MCA that is arising lateral to the optic chiasm, and it is going further laterally in the Sylvian fissure. In this image, the contralateral side of cerebral hemisphere is also removed. We can see the lentiform nucleus, and we can see both the middle cerebral arteries symmetrically and ventriculostriate arteries arising from the middle cerebral artery. So about discussing the course, as it passes below the anterior perforated substance, it gives rise to a series of perforating branches that are referred to as lenticulostriate arteries. In this image, we can see the lenticulostriate arteries arising from the M1 segment of middle cerebral artery. After passing laterally towards the Sylvian fissure, the middle cerebral artery M1 segment turns sharply posterior-superiorly at the curve that is known as genu to reach the surface of the insula. So laterally, the M1 segment is passing and it curves posterior-superiorly and takes a turn of about 90 degrees. This point is known as genu, and it further goes towards the insula and is known as the M2 segment of middle cerebral artery. At the periphery of the insula, the branches pass to the medial surface of the operculum of frontal, temporal, and parietal lobes. Its branches also pass around the opercular to reach the cortical surface that is known as the M4 segment, and it supplies most of the lateral surface and some of the basal surface of the cerebral hemisphere. We will be discussing the segments of MCA in detail. So this image is another image in which we can see the M1 segment arising from the ICA going laterally, and it takes a curve at genu and goes further towards the insula, and this segment is known as M2 segment. It's also called insular part of MCA. It further goes and at the circular sulcus, it then continues as M3 segment or the opercular segment. And here we can also see M4 that are known as cortical branches, and it is the fourth segment of MCA. So the segments of middle cerebral artery, it is divided into four segments. The first is M1 sphenoidal, M2 is insular, M3 is opercular, and M4 is cortical. This image is showing the frontal and parietal lobes. In this A image, we can see the insular cleft, and the B image is the sphenoidal compartment of Sylvian fissure. In this image, the blue colored is the M1 segment, the green is M2 segment, yellow one is M3, and red is M4 segment. So on further dissection, the M1 segment is blue, it curves at 90 degrees. This is genu. The green one is M2 segment. Then M2 segment at circular sulcus again turns at 180 degrees and it becomes the M3 or the opercular segment, and it further goes towards the cortex and known as cortical branches or M4 segment of MCA. This is further orientation of middle cerebral artery. Here we have divided in cut sections. The image A is the first cut section in which we can see the M1 segment that is colored blue. It goes and then further it continues as and turns at Genu, and as we have discussed, it is then becomes the M2 segment. Then again it turns a 180 degrees angle, and then it continues as M3, and the second 180-degree turn, and then it continues as M4 segment. So in this image, as we have previously seen, after arising from the internal carotid artery, the M1 segment of MCA courses laterally towards the Sylvian fissure. It curves at the Genu. It continues as M2 segment at the Insula. Then it further goes and it curves at the circular sulcus, continues as M3 segment, that is the opercular segment. This diagram is showing the Sylvian fissure and the central sulcus. Here we can appreciate the M2 segment of MCA, the M3 segment, that is the opercular segment, and M4, that are the cortical vessels of MCA. On further dissection, we can see there is a M2 segment that it curves at the Lyman insula, and it continues in the insula, and then at circular sulcus it turns and it is known as M3 segment. This is the transverse temporal gyri, and its anterior most part is known as Heschel's gyrus. In this image, we can see the superior trunk and inferior trunk. The M1 segment is divided into the superior trunk and inferior trunk. And after the bifurcation, it then turns at the Genu and again continues as the M2 segment. Here we can also appreciate the superior trunk and inferior trunk of the M1 segment. Then it further continues as M2 segment, and further it is going as M3, and on the cortical surface we can see the M4 segment of MCA. This is further on further dissection and retraction, we can now see the M3 segment. The vessels are on the temporal surface. The M3 vessels are on the temporal surface, and these are the M2 vessels, and M4 are on the cortical surface of brain. So now briefly discussing about the M1 segment. The M1 begins at the origin of middle cerebral artery, as we have seen, and it extends laterally within the depths of the Sylvian fissure. It courses laterally, roughly parallel to and approximately 1 centimeter posterior to the sphenoid ridge in the sphenoidal compartment of the Sylvian fissure. As we have seen, this segment terminates at the site of a 90-degree turn that is known as Genu, located at the junction of sphenoidal and operculo-insular compartments of the Sylvian fissure. This is an anterior view where we can see the M1 segment after arising from the carotid artery and the lenticulo-striate vessels, as we have discussed before, that are arising from the M1 segment of MCA. In this image, we can now see clearly after arising from the internal carotid artery. This one is the M1 segment of middle cerebral artery. It continues, and here it takes a turn. This point is known as Genu. Then it further goes as the M2 segment, that is also known as insular segment. It goes further and then it turns at the circular sulcus, and it becomes the M3 or the opercular segment of middle cerebral artery. The Sylvian point is the point, this is the Sylvian point. This is the point where the most posterior part of the MCA turns away from the insula and goes towards the cortical surface. So the M1 is subdivided into a pre-bifurcation and post-bifurcation part. The pre-bifurcation segment is composed of a single main trunk, and it extends from the origin of the M1 segment, that is after division of ICA till the origin of till the bifurcation of M1 segment. The post-bifurcation trunks of M1 segment run in parallel course, and it diverges only minimally before reaching the genu. This bifurcation occurs proximal to the genu in almost 90% of the hemispheres. So in this image, as we have discussed, we can see the superior trunk and the inferior trunk of the M1 segment. This one is the superior trunk and this one is the inferior trunk. This is the genu, and it further goes down and continues as the M2 segment of middle cerebral artery. And this is on the opercular surface. These are the M3 segments of the middle cerebral artery, and M4 segment, that is the cortical segment that supplies on the lateral surface of hemisphere. The M2 segment, as we have seen, it includes the trunk that lies on and supply the insula. This segment begins at the genu, where the MCA trunks passes over the Lyman insula and terminates at the circular sulcus of the insula. So as we have seen, this is the genu, and M2 segment starts from the genu. It continues, it then turns around, and it then continues as the M3 segment, and it terminates at circular sulcus, and from there it becomes the M3 segment of middle cerebral artery. This is another image of the anterior surface of upper surface of the temporal lobe. Here we can see the M2 segment after the genu. It continues, it goes on the insular surface, and it then gives rise to the M3 segment. And on lateral surface, on the cortical surface of brain, we can see the M4 segment of MCA. We have seen this image previously. Now again, we can appreciate the insula in this image. We can see the Lyman insula, the Sylvian vallicula, the M2 segment of middle cerebral artery, the M3 segment of middle cerebral artery, that is the opercular segment, and on the cortical surface is the M4 segment. The M3 segment begins at the circular sulcus of the insula and ends at the surface of the Sylvian fissure. The branches forming the M3 segment closely adhere to and course over the surface of the frontoparietal and temporal opercular to reach the superficial part of the Sylvian fissure. The M3 segment, as we have discussed, it starts at the circular sulcus and it supplies the operculum, and then it terminates at the cortical surface, at the surface of the Sylvian fissure, and it then becomes the M4 segment of MCA. Now discussing about the turns in the M3 segment of middle cerebral artery, we can see the blue colored image is the M1 segment, the green is the M2 segment. This is the first 180 degrees turn, and from here the M2 segment becomes, that is the yellow colored image, it becomes the M3 segment. Then it again turns 180 degrees and it becomes the M4 segment, and it supplies on the cortical surface of the brain. In this image, we can see the M1 segment after origin of the MCA. It goes laterally towards the Sylvian fissure. Here is the genu. It takes a 90 degrees turn. It then further becomes the M2 segment. The M2 segment continues from the genu till the circular sulcus, and it further becomes the M3 segment that continues from the circular sulcus till the surface of the Sylvian fissure, and M4 segment supplies on the cortical surface of the brain. The M4 is composed of branches, as we have discussed, to the lateral convexity. They begin at the surface of the Sylvian fissure and extend over the cortical surface of the cerebral hemisphere. In this image, we can see the M4 vessels, M4 segment of middle cerebral artery. These are supplying on the lateral surface of the cerebral hemisphere and or the cortical surface of the brain. The posterior branches goes in line with the long axis of the Sylvian fissure, and the anterior branches of M4 takes a sharp upward or downward turn. Here is another image. We can see the origin of MCA. There is M1 segment, and this is the genu. It is a turn. Here the M1 segment takes a 90 degrees turn, then it becomes the M2 segment. It goes till the circular sulcus, and it becomes the M3 segment of the MCA. In this picture, we can see the Sylvian point. The Sylvian point is that point where the M2 segment of MCA, the most posterior segment, takes the turn, and it goes away from the insula towards the cortical surface. And as we have seen, this is the M1 segment, this is the M2 segment of middle cerebral artery. In this image, we can appreciate the M1 segment, the genu, the M2 segment of middle cerebral artery, the M3 segment of middle cerebral artery, the Sylvian point, as we have discussed, that this is the point where the most posterior branch of MCA turns away from the insula towards the cortex. The perforating branches of middle cerebral artery. The perforating branches enter the anterior perforated substance and are also known as lenticulostriate arteries. There are an average of 10 lenticulostriate arteries per hemisphere. These lenticulostriate arteries arises from the pre-bifurcation part of M1 in every case, and from the post-bifurcation part of M1 segment in half of the hemispheres. These are divided into lateral, intermediate, and medial lenticulostriate arteries. The lateral and intermediate groups supply the internal capsule's upper part, the body and head of the caudate nucleus. The medial lenticulostriate vessels supply the lateral part of globus pallidus, superior part of the anterior limb of internal capsule, and anterior superior part of head of the caudate nucleus. Now discussing about the cortical distribution of middle cerebral artery. It includes majority of the lateral surface of the hemisphere, all of the insular and opercular surfaces, the lateral part of the orbital surface of the frontal lobe, the temporal pole, and lateral part of the inferior surface of the temporal lobe. Here is a diagram. It is showing the territory of MCA. It supplies in total of 12 areas, starting from the orbitofrontal, then prefrontal, then the precentral area, central area in the frontal lobe. In the parietal lobe, it supplies the anterior parietal, posterior parietal, and angular gyrus. In the temporal lobe, it supplies the temporopolar, anterior temporal, middle temporal, posterior temporal, and temporo-occipital areas. The branching pattern of MCA. The variations can be bifurcation into superior and inferior trunks, trifurcation into superior, middle, and inferior trunks, or multiple, that is 4 or more trunks. However, in 75% of cases, MCA is divided into bifurcation. 12% of cases, in 12%, there is trifurcation. And in 10%, it gives rise to multiple trunks. This is an image showing the bifurcation, and bifurcation is divided into, in image A, we can see the equal trunks, that is the superior trunk and inferior trunk. It is mostly in 12%, it is in 18% of cases. The B image is showing bifurcation, in which there is domination of inferior trunk, and it is about common in 32% of cases. And the C image is showing bifurcation, in which the superior trunk is dominated, and it is in about 12% of cases it is present. The D image is showing trifurcation, and it is, as we have discussed, in 12% of cases, trifurcation into 3 trunks. The 3 trunks, that is it supplies the frontal lobe separately, the parietal lobe, and the temporal lobe. And the E image is showing multiple trunks. In E image, the 2 trunks are supplying the frontal lobe, the 3 trunks are supplying the parietal lobe, and 4 trunks are supplying the temporal lobe. It is present in 10% of cases. Stem arteries, these arise from the trunks and give rise to the individual cortical branches. This is an image showing the stem arteries. The central is the most common pattern, and at the periphery, these are the 3 variations in distribution of stem arteries. The yellow shaded, yellow and orange is the supply of frontal lobe. These are from the 2 stem arteries. The yellow one is from 1 stem artery, and orange of that is supplying the central area is from the 2nd stem artery, and it is present in 22% of cases. The next is parietal area, which is of 40%, and it is supplied by 3 different stem arteries, all shaded differently. The temporal area is supplied by 4 different stem arteries. The temporal pole and anterior temporal area from a single stem artery, the middle temporal, posterior temporal, and temporo-occipital from other 3 different stem arteries. These are the variations at the periphery that can be of 18%, 14%, or 10% in frontal lobe. In parietal lobe, the variation can be 32%, 22%, or 6%, all shaded differently. And in temporal lobe, it can be 12%, 12%, or 16%, shaded differently. So now discussing about the Sylvian veins, in this image, we can see the superior Sylvian vein. Here, a vein of Tollard, which connects the superior sagittal sinus which connects superior sagittal sinus to the vein of Tollard, and it drains into the superior Sylvian vein superiorly. And below, we can see is the vein of Lebbe. It connects the transverse sinus with the superior Sylvian vein. In this image, on further dissection, we can see the superior Sylvian vein. Inferiorly, we can see the vein of Lebbe, which connects the transverse sinus with the superior Sylvian vein. And we can also see deep Sylvian vein. The transverse temporal gyri, posteriorly, it is known as plenum polare. Plenum polare is the area without sulci. Here, this is an enlarged view. We can again appreciate the superior Sylvian vein. We can see the insula, the vein of Lebbe, which connects the transverse sinus with the superior Sylvian vein. And we can see the deep Sylvian vein. In this image, on further dissection, we can appreciate the short gyri above the circular sulcus, the long gyri below the sulcus, the transverse temporal gyri, the insular vein, and the superior Sylvian vein. In this image, after retraction of the temporal lobe, we can see the Heschel's gyrus, which is the most anterior part of the transverse temporal gyrus. We can see the insular vein, the vein of Levy, which connects the transverse sinus with the superior Sylvian vein. We can appreciate the deep Sylvian vein and the insular vein. So now discussing about the radiology, this is an image from 4-vessel angiogram. We can see the M1 segment here that starts after bifurcation of ICA into ACA and MCA. The first is the M1 segment. The M1 segment, as we have discussed, it starts from the origin till the genu. Then the M2 segment from the genu till the circular sulcus. Then the M2 segment is also known as insular segment. Then the opercular segment, or the M3 segment, that starts from the circular sulcus and it goes till the surface of the Sylvian fissure. And then on the cortical surface, we have the M4 segment, which is also known as cortical segment of middle cerebral artery. In this image, we can appreciate the branches, the cortical branches, as we have discussed previously, the anterior temporal branch, the middle temporal branch, the posterior temporal branch, the angular artery of the parietal lobe, posterior parietal. Then in frontal lobe, we can appreciate the precentral, the operculofrontal, and the orbitofrontal vessels. So now, Dr. Saad, can
using the chat box, can you please answer the questions that are asked by Dr. Daniyal? So Dr. Daniyal, what's the question for this picture?
Here it is, which is the segment that is highlighted here?
So can you put the pointer on the?
Sir, this one, that
this
is
one. So people,
the more bright color, red color.
So Dr. Pravat says that this is M4. Let's wait. Dr. Afifa thinks that this is M3. So so there are different answers. People, most of the people are saying that this is M4, or they're confused between M4 and M3. Dr. Ariba said that this is M2. So can you explain which segment it is?
So this is the M3 segment. The answer is M3 segment, as this is the superior view of the temporal lobe. Here we can see this is the M1 segment, genu, M2 segment, and it curves, and then at the surface of the insula, it is the M3 segment of MCA.
Okay. Can you move on?
Yes, sir. This segment that is more bright, that is highlighted, what is this segment?
So most of them are saying that this is M2, Dr. Oswin, Dr. Reba, Dr. Parvat.
Yes, sir, they are all right.
So Dr. Yasir is saying that M2 traveling across the insula.
Now the next image that is highlighted here, which is this segment that is highlighted?
Yeah, most of them are right. This is the M1.
Yes, sir. They are all correct. So in this image, the vessels that are more bright highlighted, what is the answer?
So Dr. Reba, Dr. Oswin, Dr. Priyanka, they're all saying that this is M4.
Yes, sir. M4. So the area that is colored green in this image, what is this image?
Dr. Osman is saying that this is the Sylvian fissure.
Yes, sir. Dr. Osman is right.
This one was easy. Can you move on?
So in this image, the vein colored blue, what is this?
So, guys, what is this vein called? That you see that is marked in blue. Which Sylvian vein? Dr. Iba is saying this is a Sylvian vein. Dr. Osman is saying this is the superficial Sylvian vein. Most of them are saying this is the superior Sylvian vein. Sorry, not superficial, superior Sylvian vein.
Superficial Sylvian vein.
Superficial Sylvian vein.
Yes, sir.
Okay.
Now, what is this vein that is colored blue?
So most of them are saying, Dr. FIFA, Dr. Pravad are saying this is the vein of Tollard, Ariba, Osman. Yeah, they're all, are they right?
Yes, sir, they are all right. So in this image, the arrow, red colored arrow pointing at which structure?
So I think you've taught them well. They're all saying that this is the M1 segment. Dr. Priyanka, Dr. Osman, Dr. Ariba.
Yellow colored arrow.
So, yeah, it's too systematic, you know. They're all saying this is M2. I think one of them mistakenly wrote M1. Yeah.
Yes, sir. It is Genu and it can be M2 segment.
Only Dr. Mujahid Hussain said that this is Geno.
Yes, sir. Then blue colored arrow is?
Dr. Pravad is always the first to answer. Dr. FIFA, Dr. Iba. Most of them are saying this is M3.
This is a blue colored arrow is showing the M2 segment of middle cerebral artery.
So basically the yellow is the Geno, where
Yes,
the
sir.
M2 is starting, and the blue color itself is M2. Now they're all correcting themselves. Yes, this is M2.
Yes, sir. And the green colored arrow is pointing towards?
So what is this green color arrow pointing towards, guys? Dr. FIFA is saying this is M3. Dr. Pravad is saying this is M4. Dr. Ariba thinks this is M3. So they're confused between M3 and M4.
Sir, the answer is M4.
Okay. So can you show them the M3 in this image?
In this image, of this is the M2. These are the M3 vessels, and on the cortical surface is the M4.
M4. Okay. Okay, can you move on?
Thank you, sir.
Okay. Thank you, Dr. Daniyal, for your presentation. It was very eloquent. I will now request Dr. Jooma for his expert opinion and for his points towards at the end of this presentation. Dr. Jooma.
Yeah, thanks, sir. So first of all, a little bit of confusion between M3 and M4 is because the divisions are already made by looking at a brain surface. So when you look at a brain surface and you see the Sylvian fissure, you can see small arterioles climbing out of the surface out of the Sylvian fissure and going onto the surface of the brain. And anything that's inside is either the trunks, which is 2, or climbing over the lips, which is 3, and then going onto the surface is 4. And the confusion was because of the way the images were presented. But I guess everybody understands what Daniyal had said initially, that when you're out of the surface, outside the Sylvian fissure, that's an M4, and the segment where the vessels are climbing over the lips is a 3. The one thing that there seems to be more confusion about, of course, is the veins, and I really do want to suggest that it's nice to honor old folks like the anatomist Trollard, French anatomist Trollard, and the anatomist Labé. But it's best to think of, on the surface, there are three major veins that you can see. The first, which Daniyal kept calling the superior, is actually superficial. The middle superficial cerebral vein overlies the Sylvian fissure, and it runs from the back of the Sylvian fissure, and it goes and drains into the sphenoidal segment of the dural sinus. The superficial sinus that you see when you pull the temporal lobe back. The other vein, which goes up to the sagittal sinus, is the superior anastomotic vein. And the inferior vein, which runs back to the sigmoid transverse junction, is the inferior anastomotic vein, which we are calling Labé. So it's best to see it as a venous system in which there's the superficial middle cerebral vein going forwards. There's the superior anastomotic vein going up along the central sulcus, and the inferior anastomotic vein going back along the back of the temporal lobe. I think that the other thing that might have been a little helpful, you actually open the Sylvian fissure most often for an aneurysm when there's a middle cerebral aneurysm, and that's the best indication. But for a lot of people, they like to open the Sylvian fissure as they're approaching anything around the carotid optic nerve complex. So in that situation, these vessels come into play, because the best strategy is to find a place where the Sylvian fissure looks a little wider, and for most people, incidentally, another thing, Daniyal, on your presentation, you kept talking about the Sylvian point. So, that Sylvian point is the angiographic Sylvian point. It's the point on the angiogram where you see the last curve, and it's at the back. Whereas for most surgical anatomists, there is an anterior Sylvian point and there's a posterior Sylvian point. And your Sylvian point is the posterior. The anterior is right at the stem, just behind the Lyman insula, where the Sylvian fissure has a wide lake, and that a wide lake is where the carotid, the middle cerebral has taken that right turn at the genu and is climbing over onto the insula. And if that's well exposed, that's a very good place to start by opening the Sylvian fissure when you're opening it proximal to distal. But most people like to open it distal to proximal, and that you start just somewhere in the middle that's convenient, and you try and enter into the Sylvian fissure. And when you do, you follow an artery, which an M4 artery to M3 to M2 trunk. And once you're there, then you can move back out, forwards or backwards, to open the whole Sylvian fissure, which is, I think, another subject of discussion that residents must have. What is the best way to open the Sylvian fissure, and how do you do it in a way that makes it easy and facile? Because sometimes the opening is so easy in an elderly brain with large CSF lakes. In a young person with chronic raised intracranial pressure, let's say because of a tumor, the frontal and temporal lobes are so interdigitated that opening becomes extremely difficult. So, as I said, one of a further discussion can actually be about what are the strategies and what are the ways of opening the Sylvian fissure to expose the pathologies of the insula and the paracellar region. And as I said, I think that's a subject of another discussion. I just want to say one thing in conclusion. This anatomy is really very important, because increasingly we're operating on tumors of the insula. And these are people who have a tumor that's going to actually end their life prematurely. Once you have a glioma, you know pretty much that your life is going to end prematurely due to this tumor. It may take a year or two, it may take up to 5 or 7 years. But eventually, if in the course of operating on that patient, you also render him hemiparetic because you've injured either a lenticular striate perforator, or a long middle cerebral perforator, or a middle cerebral trunk. If you injure any one of these, you're doing the patient a huge disservice, because his now brief life is then compromised with a hemiparesis. And so it's a huge responsibility to understand the anatomy so that you can operate on the region without injuring any of the 3 critical kinds of vessels that may cause hemiparesis. So, Saad, that's what I had to say.
Thank you, Dr. Jooma. We have 2 questions. I've already answered partly for the first question. This is the first question is from Dr. Miguel, and he wanted to ask between the relationship between the insular point, anterior and posterior, and the Sylvian point, and the anterior and posterior.
Yeah. So as I said, the anterior Sylvian point is where on the brain. The horizontal ramus and the ascending ramus of the inferior frontal lobe come together at the tip, just where the stem of the Sylvian fissure is, and the CSF there forms a little lake, and it's a wide point. But it's a very deep point when you're coming from the surgical point of view. So it's not very obvious until you've resected the sphenoid ridge. Once you've resected the sphenoid ridge down to the orbital floor, then you can see that point really very well. And as I said, the Sylvian point is at the back, and that corresponds really to the angiographic Sylvian point.
Thank you for the answer. Now, Dr. Bushra wants us to point, if possible, on the scan, the anterior and posterior Sylvian point. Daniyal, can you put up your presentation again? Maybe we can give it a try, if possible. Okay, Daniyal. So she wants if we can point out where the anterior and posterior Sylvian points are.
I'm not seeing the screen. Is that?
No, he's putting it up, sir. He's putting it up.
Okay. Although, Saad, the anterior Sylvian point that we're talking about is quite frankly, best seen on an MRI. On an MRI, who's asked that question? Dr. Bushra. Bushra, if you take a T1 MR and look at the sagittal sections, the point just when you start seeing the Sylvian fissure, where you see a wide area in front, is really the anterior Sylvian point. And it's just, and as you scroll the sagittal images back, where you see the horizontal ramus and the ascending ramus, where those join, that's where the anterior Sylvian point is. On this, on the images that Daniyal is showing you, it corresponds to the vallicular. You remember on his images, there's a label, vallicular of Sylvian fissure. That's the anterior Sylvian point.
Thank you, Dr. Jooma. Daniyal, is it possible for you to put up an MRI maybe, or is it too much to ask?
Sir, I'm sharing the screen. I will show that point, Sylvian vallicula, and also I'll try to show an MRI.
Maybe a sagittal view. In the meantime, if there are any other questions from Dr. Jooma, we'll be happy to have that. So, Dr. Jooma, when you're talking about Sylvian Fissure dissection and most people going from distal to proximal, which trunk do you follow? Most people tend to follow the frontal trunk and avoid the temporal trunk. Is there a significance to it regarding?
No, Saad, as I said, it's just so much easier to go from distal to proximal because when you open up the dura, it's the proximal point that is further up the brain towards you, towards the surgeon. And then you have to pick out a good size arteriole of the M3 M4 region, and then follow that in. Regarding the issue, if you do a good Sylvian Fissure dissection, you'll notice that the inferior trunk tends to travel in that gap between the opercular and the insula, which they call the inferior circular sulcus.
Mm-hmm.
So let me repeat that. The middle cerebral trunks, the inferior trunk tends to be in that corner, the inferior circular sulcus between the opercular and the insula, as you open it up. And so the dissection in that region to expose the insula is much easier than what you're saying, because on the frontal side, the one or two trunks of the middle cerebral, the M2 trunks, they don't hug the circular sulcus the way the temporal one does. So there, the dissection to show the superior the sulcus is a little more difficult. And you have to do a little more pulling on an area that you don't really want to retract too firmly. So it's much easier to actually expose the lower trunk in the lower sulcus. And then as you decompress the insula, move your way up into the frontal, the frontally based sulcus. Just another point is that there are more M3, M4 branches coming out from the frontal operculum, from the frontal side. So those hold the frontal lobe down a little more firmly to the insula. Saad, is that clear?
Yeah,
is that point clear? There are more branches coming out and going toward the frontal side. So they're holding the frontal side down. And that's why the temporal is actually much easier than the frontal.
And this strategy remains same whether this is an aneurysm or a glioma?
No. So in a insular glioma case where you're doing a trans-Sylvian approach, you have to open the Sylvian fissure really very widely. You 100% have to see the inferior circular sulcus, and you have to be close to seeing the superior. But you have to understand that what's making this maneuver difficult is that the whole insula is swollen up towards you by the underlying tumor. So, but the objective must be to display the insula completely, not up front, but in stages. On the aneurysm side, no, you just need to be able to see the trunks. And once you clear that you're looking at a large M2 trunk, trace that back to the bifurcation, which is where the aneurysm is going to be. You don't need to see the superior inferior sulcus in this case.
So I don't know, Doctor. So then another question, which Dr. Miguel is asking: is there retrograde dissection of Sylvian fissure? Is it better to do it in some cases? Preferred?
Yeah. So, Miguel, what we're talking about again is that you can open the Sylvian. See, there's two ways of doing this. So first, you do your craniotomy. Then you resect a little bit of the bone of the sphenoid ridge. Okay. Now you have a choice. If you want to open the Sylvian fissure, you can either be towards the back of the fissure, find a branch and follow it in, and as you go in, work towards the frontal side towards the frontal side of the large middle superficial cerebral vein, because you want that vein to continue to be connected to the dural sinus on the sphenoid ridge. Miguel, I hope that's clear to you. On the other one, if you have a good exposure because you've taken a lot of the bone from the sphenoid ridge away, you can approach the thing. You can approach the Sylvian fissure from in front, close to the stem, and all you have to do is take a knife and make a little nick in the membrane of the Sylvian fissure. You'll see CSF gushing out of this little cut that you've made. Unless, of course, you've been silly and put in a lumbar drain before and drained all the CSF off. If you haven't done that, when you make that little nick at the stem, CSF gushes out, and that allows you an entry point to work back from proximal to distal. And that's a reasonably good. A lot of people do that. I personally am much more comfortable and feel easier because, Miguel, once you start working under the microscope, it's very difficult to get to high accuracy right away. It takes your hands a few minutes to adjust, and the margin of error at the back distally is more than the margin of error in the front, close to the stem. So I like to be able to sit under the microscope and start working. And as I get to the critical part, which is towards the genu of the middle cerebral, my hands are now used to working under the microscope. Miguel, is that clear, I hope?
Thank you, Dr. Jooma, for this answer. I think Dr. Daniyal has a handful, and I think it's difficult. I think he cannot put up that MRI. I thank you, Dr. Jooma, for joining us for 2 consecutive sessions, and I hope this was helpful for the candidate as well. I thank you all for joining. We'll meet you next week. I thank again Dr. Jooma for joining us. Sir, it was a pleasure to have you.
Right. Thank you, Saad. Thanks for the invitation, Saad. And good luck to all the residents.
Thank you, sir. So we'll meet next week. Thank you all for joining. Take care of yourself.